So I'm going to cover a few things today. So for those of you who don't know me, I lead the neuropsychology team at the Children's Hospital and also lead a research programme at the University of Glasgow, looking at a range of neurological disorders, not just brain injury, but a range of neurodevelopmental and neurological syndromes affecting children. And today I want to kind of look at kind of longer term recovery issues. But before I do that, I just want to remind everyone that often we can think about brain injuries as being traumatic brain injuries, so something has occurred that's affected a child with a normally developing brain, and then there's a big change. But actually, brain injuries are much more complex than that. And brain injuries can occur even prior to birth. So we often don't think about brain injuries that occur at that stage as a brain injury. There's a term called congenital, which just means present from birth, and it's quite an outmoded term now. It's a bit of a Victorian term, which means something happened that we didn't know about, but now we do know why the cause of lots of brain injuries that occur very early in development. And it might be that some people here have had a child or indeed have had a brain injury that wasn't a traumatic brain injury, but they are very important causes. This slide just kind of shows the things that can happen right from conception right up to year one. So you can have things like exposure to toxins that can damage a normally developing brain. It could be drugs or alcohol exposure, and that's a big issue in the west of Scotland, particularly with exposure to alcohol. Intra-uterine infections. So I see the encephalitis truster here, but you can have infectious disorders that can damage your brain right across your lifespan, even before you're born. There can be perinatal stroke, so that's unusual, but they do happen. Birth asphyxias, so there can be a physiological or mechanical problem that injures a normally developing brain even before or about around the time of birth. And then as we move through year one, sadly one of the more common causes of an early brain injury is non-accidental injuries. So there's lots, and then there's things like meningitis, the kind of more common infections. So there's lots of acquired brain injuries that occur very early on in development. And that's important to know about because we often think about neonatal brain injuries, so when there's been hypoxic ischemic insults. And we kind of think that if that's happened, you might have an outcome like cerebral palsy. But you can also have brain damage that doesn't present with observable motor problems, but where you do have quite a significant cognitive disorder, things like developmental amnesia that are very rare, poorly recognised. But there's lots of things that can happen that aren't actually well understood out with specialist contexts. But if we think about the main causes of traumatic brain injury then, so for infants in that first year, it's falls or abusive non-accidental head trauma are the kind of leading causes in year one of a traumatic brain injury. And then in preschool it becomes falls, and then from kind of 5 to 14 it's falls or being struck by an object on the head. And then in adolescence the primary causes are sports injuries, bicycle or motor vehicle accidents. So the kind of causes sort of change through the child's lifespan. So we've got these kind of two peaks where we've got children pre-5 and then in kind of mid to late adolescence are where we see these big spikes of numbers of presenting traumatic brain injuries. And we know that the risk of injury is greater in boys, and it's also greater in children who are coming from more deprived areas. So there's a lot of discussion and a bit of controversy just now about mild traumatic brain injuries. So I often see social media feeds are kind of full of studies and thoughts, and I think it's good that sports concussion management has been given a lot more space. That's a major theme in this city with the work of, I've just forgotten his first name, Dr. Willie Stewart, who's been doing all this work on the risks of neurodegeneration after being involved in professional sports like soccer and rugby. But it's really important how we think about managing sports concussion in children and young people as well, so I think that's really good. However, we do strongly expect the vast majority of children after a concussion to completely recover within a couple of weeks. So then the interesting thing is, well, what's going on for those few percent maybe up to 5%, who don't show this normal recovery over time. Is it actually to do with a brain injury, or are there other factors that are going on? And because these brain injuries are very common, so mild TBI makes up, about 90% of traumatic brain injuries, because it's a large group, significant proportions of them will also have other stresses going on. It might be things in family function, pressures at school, etc. So we've got to think, well, what is it that's making this young person not recover so well? And is it the brain injury, or is it the other factors? And I noticed again this week there's another major study that came out where they've used really sophisticated imaging techniques, so things like diffusion tensor imaging, to look at what might happen in the brain after a mild TBI, and shown that there are changes. But when you look at these studies, the group with changes on imaging are not the group who present with problems later. So it's an interesting thing, but what we want to do is to avoid over-pathologizing mild TBI and give the expectation that you're most likely to recover, and if you don't, possibly other things going on. So just to bear that in mind. So before I kind of move into the kind of what makes a difference with recovery, I'm now going to ask Lindsay to come and speak to you about the Paediatric Major Trauma Centre. Thanks, Lindsay.
Hi everybody, so I'm Lindsay and I'm 21 today, as I'm sure you'll think. I'm just going to just briefly give you a sort of overview of the what really my role encompasses and what the Major Trauma Centre is. So I do have some of my major trauma colleagues here today from the adult side, so they will, I'm sure, back me up. So a paediatric presentation isn't a paediatric presentation without lots of pictures, so you will have to excuse the pictures. So this is our major paediatric trauma centre in Glasgow. This is our launch event back in August when we launched as a major trauma centre, so lots of balloons, lots of nice pictures. As a sort of group, we obviously are formed as part of the NHS, but we also form part of the Scottish Trauma Network, which is a much wider sort of environment. There are 4 bits to it, so there's the north, south east, east and west. So I work at the Children's Hospital in Glasgow, and we make up the West of Scotland Trauma Centre. So this is just really a sort of basic, outline of what. So Major Trauma Centre, if you need neurocritical care or any sort of neurosurgical intervention following a head injury, you will come to the Major Trauma Centre. However, we do have trauma units within the sort of West of Scotland, which are all listed on there. And again, these guys will see major trauma, they will see some sort of, like Liam said, concussions, some head injuries. These guys will be able to deal with that type of thing. However, what they can't provide is neurosurgical intervention. And I think the idea of the Major Trauma Centre is that, you can't provide a neurosurgeon, a cardiothoracic surgeon, a general surgeon at every hospital in Glasgow. So that is why we have established the Major Trauma Centres. And again, when you get to the scene, it doesn't necessarily always need, like the picture at the bottom is of 2 children that we saw about 1.5 years ago, I think, who were directly straight to the Major Trauma Centre. But not all brain injuries require that level of care. There is ambulances, and again, they would probably go to your sort of more local major trauma units. We do often see these kids who do attend at trauma units. They will come back to some of our clinics due to sort of concussion follow-up and things like that. So they will eventually always come back to us. Like Liam says, kids who have concussion are, as equally as important. They might have negative CT scans. They often don't have any sort of official follow-up. And again, I think sometimes these kids can sort of slip through the net a wee bit, and they're the kids who need sort of ongoing support, going back to school and things like that. We are in the process of trying to sort of develop some sort of concussion clinic to try and scoop up these kids to make sure there's sort of equity of care throughout. And again, you will have your local emergency hospitals. Again, they can deal with sort of simple concussions. I was just laughing at Chris earlier when he said, if it matters to you, it matters to Digby Brown. As a Scottish Trauma Network, we also have a slogan, which is saving lives, giving lives back. So it's about saving lives, but it's also as equally as important to give lives back. The slide at the bottom, that's Jenna, Mark and myself. So as major trauma coordinators, our role is really to coordinate care. Nobody prepares for a major trauma. When patients present to the Major Trauma Centre following a major trauma, there's lots of different specialties looking after them. Life is totally turned upside down. And as major trauma coordinators, our role is to coordinate that care and be a single point of contact for the families. Be there, be able to answer all these questions. And again, If they come in with a head injury, they might also have a broken leg. The neurosurgeon doesn't care about the broken leg, as equally the orthopaedic surgeon doesn't care about the head injury. So it's really important that we provide a holistic approach to these kids. And I think in order to give life back, that is a massive part of a brain injury journey. It's a very short space of time to save the life in A&E. However, as some of you will probably know, it's a prolonged period of time to get some sort of quality of life back. And again, this slide just shows you the whole MDT approach that we have. It's not just about the neurosurgeon who saved the life. We've got physios, we've got occupational therapists, speech and language therapists. It's a massive, massive team who are involved in this. We also work really closely with schools. Again, as children, it's really difficult to reintegrate kids back into some sort of normality. Myself, I've done a quality improvement project recently, and it's all about just reintegrating kids back into school. How can we make that journey following a TBI or any type of brain injury smooth and get them back into, school's legal, everybody has to go, whether we like it or not. So it's really important as part of that, reapproaching into integration to make it as smooth as possible. And again, we are a paediatric environment. We're really lucky. We've got, play teams and things like that who, again, are very, very pivotal in trying to get some sort of normality back to these kids' lives. The diagram on the right is just really a sort of patient journey. Again, not everybody who has a brain injury will need a helicopter, will need a Coast Guard helicopter or anything like that. So this is just the kind of type of journey that our patients follow. The picture of the people in the helicopter, that is of two kids, like I say, that we retrieved from Dundee. And the picture at the bottom, I know it's quite small to tell, that is them post-recovery a year and a half later. So it's so lovely to see that we get to see these kids coming back a year and a bit later. And this is just really a brief sort of criteria. Paediatrics, fortunately, we don't see masses and masses of head injuries, sort of traumatic head injuries, but we do see a substantial amount. And again, we are the primary specialty for anybody requiring neurosurgery or any sort of type of neurology. So like I said before, the kids who have got concussion, who maybe need some sort of psychological follow-up, we do a 2-week sort of post-discharge follow-up. And again, a lot of them, will sort of have sort of flashbacks and things like that. So I think it's important, like I say, as a multidisciplinary team approach to address all of these things. And again, we get lots of charities involved. We have Child Brain Injury Trust, who will help with all these things as well, and Headway and things like that. And again, the numbers at the bottom are just kind of with 36 traumatic brain injuries in 2020, 48 in 2021. I think that was probably because lockdown had sort of been loosely laxed a wee bit. So we've got 48 patients in and we're sort of sitting at 37. We've had a few this year as well. So again, it's just a sort of ongoing thing. And again, we work really closely with everybody in our teams to try and, as I say, make the transition as smooth as we can.
Thanks, Lindsay. That was an excellent quick overview. I think you could do a much longer talk. I mean, your work's really complex, and what always strikes me is that, you're working with families in crisis. As you say, no one plans for a major trauma. So it's not just the patient, but it's the family, and everyone can be really blown away. And I think the thing is, there's not a lot of rehabilitation work that goes on much beyond discharge at the minute. So I think a lot of families are left with significant post-traumatic stress symptoms, and there's really not psychological services to kind of follow that up. So there's still a bit of an unmet need about the longer term. So I want to think a wee bit about what we mean about recovery. So obviously, when you're in the major trauma centre, the team are working to save your life, to stabilise you, to help you with those early phases of recovery and to maximise your potential for recovery in the future. A lot going on. So there's intensity, lots of specialties. People like Lindsay who are very involved, and I think it's a big thing for the team to manage being around this much intensity and kind of trauma as well. So there's a kind of need to think about staff well-being within the mix too. Early recovery then, we're kind of thinking about the kind of months after discharge. So reintroduction to school, trying to think about how families function and thinking about the themes of loss, the themes of trauma, trying to work out how to kind of put the pieces back together again. You'll also see quite significant recovery in terms of kind of cognitive skills, and usually emotional things settling down a bit in those early months after a severe brain injury. and then that recovery trajectory kind of slows a bit after a year. You can still continue to improve, but there's a kind of natural recovery over the early months where things do get significantly better. But I think what often happens is that after that, then the specialist teams in the hospital tend not to be involved as much. And then it's, well, what are we left with? And whilst in the adult world we've got specialist brain injury teams, and actually the major trauma centre for adults, they were funded to provide, I think, half a dozen clinical psychologists to help with that. We don't have that in paediatric, so there was no funding for paediatric clinical psychology in the Paediatric Major Trauma Centre, and we don't have specialist community teams. I think the thinking is that schools are the main source of rehabilitation, or CAMs for children with kind of more mental health disorders, but CAMs aren't a good fit for this group. So at the minute, we're trying to make strong arguments that we actually do need the kind of specialist care for longer term follow-up for children after severe brain injuries. So at the moment, we're a bit frustrated with how that's gone, but hopefully things can improve. So I want us to think about, there's a very well established literature base, evidence base about what happens in the long term. So these are kind of two different themes. So on the left, we've got a study that's quite well known by Vicky Anderson's group in Melbourne. So they've been doing kind of follow-up brain injury work for decades now. And what they've shown is that at 10 years, just using an IQ test as a kind of broad measure of the cognitive impact of different kinds of brain injury, you can see that mild and moderate TBI have an average IQ, 100 or above. But if you've had a severe TBI, it's kind of lower. So in this large cohort, it was lower, but not that low. It's sort of 95. So what does that mean? Some people might think, well, it's not a big change. But to lose 5 or 10 IQ points actually is a big change. I mean, that could be a shift in terms of, let's just say you were capable of getting 5 hires. That might now mean that you only get 1 hire and three nationals. Or if you were going to go to university, maybe you're not going to university now. Or if you were going to get 5 nationals, now you're not getting any. So what might look like a subtle change on a test like that, it scales up to a significant change in someone's life outcomes. And I think that's often what's lost, because that's not going to present in a school. So the things that teachers might notice being a change, they're not going to know what their vulnerabilities really are. So we've got to think about, well, what can we do to actually improve cognitive functions, and how can we improve academic attainments and employment support? The other thing was really important. The other slide, so this is from Keith Yates' group, so another big group in the US, although Keith Yates now moved to Canada. And they've been very interested about, well, what are the other factors that make a difference in the longer term? And it's very clear that there are things, the further you get away from the injury, the more that other things matter. Things like, how your family functions, what your access to resources are, what kind of school you go to. All these things that make a difference in the general population also make a difference for kids with brain injury, but they're more sensitive to some of these markers. So this study shows that if you've had a severe brain injury and you're in a family where there's quite a lot of expressed emotion, where there's a bit of shouting, where things are just a bit more chaotic, that you're much more likely to have significant behaviour and emotion problems, 5 or 10 years later. And that's important because, it's not about, and the last thing you want to do is to make parents think, who are already traumatised, think, well, am I doing something wrong? The issue is some families are highly stressed, low on resources, need help, and what can we do to help those families to function the best that they can? Because we know that that's going to be a significant moderator of the outcomes of that child. So it's not just about the cognitive impact, it's about how we help a family to readjust, cope, and support a child in the longer term. The other thing about paediatric brain injury is that obviously because of your brain's developing, your brain continues to develop right through your 3rd decade. And I'll show an example of a function in a second, but we can't know what the effects are going to be because a lot of the abilities that we have as adults haven't emerged yet when you're a child. If you've had a severe brain injury when you're 5 or 7, you haven't yet developed the kind of skills you would expect to see in adulthood. So we don't know if they're going to develop at all or if they're going to be significantly changed. So we just don't know at that time what the effects are going to be. I wonder if I can press play on this. This is just I'm going to show you, this is the process of how grey matter, your neurons, reduce in density across your adolescence. So you'll see, as this brain becomes increasingly blue, that means that you've got fewer neurons. And you might think, well, is that good? It's actually a normal and adaptive process because we've got too many neurons. What we want our neurons to do is to form functional, connected systems through the brain. So let's just say you're all neurons sitting here, but let's just say we've got a bunch of tasks, but there's loads of us and it's diffuse responsibility, we don't know who's doing what. What we'd want is just to be left with groups who are working on tasks. So actually having fewer neurons, but who are all connected and solving problems. So this kind of process is actually really good, and this just, if this works, we'll show you. Oh, is it not? Sorry, it's a problem with embedded videos. I'm not sure if I can make that work. Oh, it doesn't matter. It just basically shows that there's a big change in the structure of the brain across adolescence. So, and then another way of looking at that is in terms of a major function. So we were very pleased earlier this year to publish what's actually the biggest study of cognitive empathy there's ever been. We did that at the Science Centre. So we had 4,500 participants who did a test of cognitive empathy. So that's about knowing what someone else might be thinking or feeling. So it's a really important ability to have in terms of managing relationships, working out what's going on with group dynamics. It's a key thing in terms of career success as well as friendship ability. And what we found that was really interesting was, so this is it's a bit small, but this is by age bands. So here, these are children 10 to 12 years of age. And then this is adolescence. And we can see that for both girls and boys that their empathy dips during adolescence. So you're actually better at these social cognitive tasks in pre-adolescence than you are in adolescence. And then look at the huge, as soon as you hit your 20s, really gets up to adult levels. So this is kind of the concept of the kind of egocentric, churlish teenager. It's not a choice. Their empathy actually is less good. And it's interesting because most cognitive skills just get slowly better in a linear way as you develop. So your IQ just keeps going up and up. But there are a few skills that go offline a wee bit in adolescence. So it's worth we need to kind of know about that developmentally in terms of how we educate kids, how we think about group dynamics, etc. That there are points in which their empathy might not be as good. And again, that kind of relates going back to changes in the brain during adolescence. So again, this developmental perspective is crucial as we're thinking about supporting kids with brain injury, because we know that friendships and social cognition are one of the areas where children after a severe brain injury can struggle. And it doesn't manifest straight away, but you know, if you're just a bit slower, if you're not good at reading stuff, if it just takes you longer to process, it makes your peer group you might be a bit more unpredictable or a bit more difficult to interact with. And we need to think about strategies to manage friendship skills, because that's a really important thing for teenagers. So, and it might not emerge until much later. So this is what we need to think about. And we also know that there are interventions that can improve that. You know, interventions that work with young people and crucially working with parents to improve those kind of theory of mind, those social cognitive skills, and that improves friendships. So again, we don't really have the resources to do these specialist interventions, but there is an evidence base that says we can do something. There's also a lot of things about, again, you know, parenting and family work that would be really helpful to do around help. So we know that, you know, if you've got quite an attuned relationship with a sensitive carer, your friendships are better, your self-esteem's higher. So, you know, again, this family-based work's really important. And again, it's not stigmatising, it's recognising that some parents... So let's just say you've had a child with a severe TBI, you've got another child with ADHD, let's just say you're a single parent, or you've low resources. How on earth are you going to have the time to do evidence-based interventions? It's just difficult. But it's not... But also I've seen, you know, parents who are quite affluent, are high in resources, but the impact of kind of loss and trauma is such that they're not in a place to kind of use normal parenting practices either. So you've got to think, what does this family need right now? Not just what's the nature of the brain injury, but what does this family need to actually adjust and to progress the needs of this young person to actually achieve well. So there's this concept of environmental enrichment, which comes for decades ago. We were studying the effects of enriching the environment on brain development in rats, and I know some people will find that a difficult concept, but this basically just proves the concept that if you enrich the environment, if you interact more with peers, with you need challenges, you need to learn things with others, you need better nourishment, and just an environment that challenges you, your brain actually develops. And I suspect that's true for children after a paediatric TBI, that you need to make sure that their environment is challenging, they've got good relationships, they've got supportive relationships, and people need to do that quite intensively, quite early on to maximise the outcome. I'm just aware of time, so I'm just going to speed up a bit. So we kind of need everything to come together. As I said, schools are the major source of rehabilitation for children. But schools are, busy places, and often teachers can have large classes. They can now, with mainstreaming, you can have a class where there's a lot of kids with neurodevelopmental issues, maybe a child with, a brain injury. It's a lot for a teacher to organise. So they do need advice. They also need a kind of a roadmap of what might be a problem at what stage. So that's again where we're struggling, because we don't have enough specialist resource to follow kids up through that journey across years. We need to think about what the family needs, what are the challenges for this family, what resources they need access to, what supports. What we want to do is to use their natural recovery. So sometimes, one day a week I've got a private practice where I'll do medical legal work, and I do this around the UK, and I'm sometimes struck that sometimes with private case management, and this is just sometimes, there can be so much of it, so you get a lot of intensity, but it can disempower the family's ability to feel in control and to actually, become empowered and skilled at parenting their child. So sometimes, usually within the NHS, we've just not got enough. But we know that we don't have too much either. So we've got to really be careful about what are the goals, what are we trying to achieve. And then, working with other agencies. So at the moment, we're not quite there. I think we're trying to develop stronger partnerships, but I think we need more specialist resource going in to help this equation to work. And the last kind of point I want to make is, it kind of matters where you work. So this is a city it is very high in deprivation. This is a map of deprivation in Glasgow, where red is the lowest decile. So this is the bottom 10% in Scotland in terms of deprivation. And you can see that huge swathes of the city are very high in deprivation, and that links to all sorts of health outcomes. But if you've had a severe brain injury as a child, then that's really increasing the challenge that you've got. People are now quite ACEs aware, this adverse childhood experience. But if you're quite high in ACEs, so it's too small to read, but things like abuse, neglect, household dysfunction, stick a brain injury on top of that, and your chance to develop through these challenges is reduced. So we do need, again, to be aware of the kind of social and geographical context that we provide services in, which might be different in an area that's much lower in deprivation, where they may be able to use, specialist interventions. Often we're working at a lower level about trying to establish a good routine in a household, about trying to think about parental mental health. So we're just far away from doing things like specialist cognitive rehab, because it's just not going to be the right thing at that right time. So you've just got to be very sensitive to the context that you're working in. Very last thing, I just want to say that we were very pleased that next year we're bringing excuse me, the International Paediatric Brain Injury Society Conference to Glasgow. So that's the biggest paediatric brain injury congress in the world, and it's every 2 years. So that's going to come next September, and I'm the chair of the organising committee, so we're definitely trying to think about how to involve service users and families in that event. So just watch this space. We'll kind of advertise that more next year. But that will put Glasgow on the map, and I'm also hoping that we can invite multi-agency partners just for Glasgow to think about what we might do to actually really meet the needs of children after paediatric TBI. So I'll stop there. Thank you.